Namaste, I'm Dr. Nishant Kanodia, working as professor and head of the department in Medical College and Shekhar Hospital in Lucknow for last 16 years. As we all know, type 2 diabetes is a long condition. It's very long. It continues almost for the whole life and keeps your body from using insulin the way it should. So people with type 2 diabetes are said to have insulin resistance. People who are middle aged or older are more likely to get this kind of disease. It used to be called adult onset of type 2 diabetes, but type 2 diabetes affects kids and teens also, so it is also known as childhood obesity. Type 2 diabetes is the most common type of type 2 diabetes available in the world, and approximately 84 million people have pre-diabetes. That means their blood sugar is on a higher side or just at the level. Today we'll talk about a patient named as Madhuri, 52 years old female. She was diagnosed type 2 diabetes for 9 months when she started to change her lifestyle and was started with metformin by her doctor. In the first 3 months, her HbA1c reduced from 8.7% to 8%, and she almost lost 6 kgs. She continued with the same drug, and the drug was increased. Patient again returned to the doctor after 9 months. She also has complaints of hypothyroid. She lives independently and exercises 5 to 6 hours a week. Her medication was metformin 1000 milligrams twice daily and levothyroxine 100 milligrams once daily. After 9 months of treatment with metformin, her HbA1c returned back to 8.1%. Her EGFR was fine. Her triglycerides were on a higher side. Her thyroid levels were pretty much normal. The only finding is that after losing weight for around 3 to 4 kgs, she again regained the weight. Her blood pressure was also on a higher side, and BMI was also on a higher side, that is 32 kilograms per meter square. So even after the intensification of the treatment, patients usually don't meet their type 2 diabetes requirements. So Madhuri also feels guilty about not able to control her glycemic profile. The early initiation of hence a combination therapy has been proposed and approach for this problem. So achieving glycemic control earlier, postponing any therapeutic clinical inertia, delaying the deterioration of glycemic controls and complications arising from it like micro and macrovascular complication that includes neuropathy, retinopathy, and cardiomyopathy, and potentially preserving the beta cell function should be the main aim of every doctor. So, to consider a dual therapy in such a patient with newly diagnosed type 2 diabetes, you should have certain things in mind. So, if the HbA1c is more than 1.5%, above the glycemic target, or if the HbA1c is above 7.5%, or your target goal is less than 6.5%. So, according to the societies like American Diabetic Association and ACE, Madhuri should be on a dual therapy immediately as her goal reaches or is intended to be 6.5 and below. So there are multiple rationale for type 2 diabetes management, multiple metabolic defects. Patient has high blood pressure, high cholesterol levels, and high blood sugar levels. Progressive disease, the disease may be running in the family and is happened to the son or the daughter also. Limited efficacy of single drugs. So single drugs may not be very efficacious for a very long time to preserve the beta cells so that there will not be any macro and microvascular complications and the need for insulin in the future. Lack of durable response with initial monotherapy. So if the initial monotherapy, the patient blood sugar is controlled, but it reverts back to the same position after a year of treatment, then it should be changed immediately. You should lower the HbA1c risk for microvascular complications and glucotoxicity to have recurrent episodes of hypo and hyperglycemias. So these findings usually has been adopted for the ADOPT trial, that is for decreasing the durability of the diabetes. So if there is a medication failure at 5 years with a monotherapy, then you should adopt for a combination therapy. These medication failures at the time of 5 years usually happens 15% with rosiglitazone, 21% with metformin, 34% with glyburide. So this doesn't mean that our patient Madhuri has failed the treatment of a disease. Because of the clinical inertia due to the clinician's fears of hypoglycemia and weight gain, it they leads to a poorly controlled glycemic control, and hence they don't prescribe multiple medications. A recent study has suggested that if the patient HbA1c is more than 7% for more than 3 years on one or two medications for diabetes, then for the good early outcomes, better glycemic control, and the reduction of the long-term microvascular and macrovascular complications, you have to use a very good combination that is efficacious in both the ways. So for such patients with inadequate glycemic control on metformin, addition of a single pill might be considered to establish the optimum glycemic control while reducing the pill burden, avoiding clinical inertia, and the compliance for the intensifying therapy. So when metformin is not suitable for such patient, a combination of empagliflozin or linagliptin or a combination of both should be added as a first-line treatment as in the initial therapy to achieve the glycemic target more quickly, particularly in such patients like Madhuri, who has a 1.5% HbA1c higher than the normal level. So according to ADA 2020 guidelines, the treatment goals involves control of glycemic control, CV risk factor management, and patient-centric approach to care. The choice of pharmacologic agents now take accounts of comorbidities in addition to the risk of hypoglycemia, impact on weight, cost effectiveness, potential for side effects, and patient preferences. Definitely, different things allows different things, and every patient cannot have the same medication. So there are clinical evidences that shows that SGLT2 and DPP4 combination is a very effective option for the management of type 2 diabetes, providing HbA1c reductions of almost 1.1 to 1.5%. It also constitutes your weight reductions, fat reduction, and a non-alcoholic steatotic hepatitis or NASH reductions in the liver. Approximately the weight reduction is of 2 kgs when they are added to metformin, which is the primary place in therapy. So still metformin should be considered as the first line therapy. And when that therapy fails, you should definitely add up to such a drug that helps in all the parameters. So this combination of AMPA and LINA, that is the SGLT2 with the DPP4 inhibitor, has the promise of cardiovascular benefit with positive efficacy data on empagliflozin and consistent cardiovascular safety data for DPP4 class. The DPP4 inhibitors have a neutral effect on ASCVD or atherosclerotic cardiovascular disease when they are added to standard care. In also another phase 3 trial, it was seen that the efficacy and safety of empagliflozin and linagliptin in combination has a better tolerability in the subjects who are given these drugs and who are given these drugs alone, and the risk of hypoglycemia and genital infections were also very less. So this fact implies that in our patient Madhuri, adding AMPA-LINA combination in addition to metformin will definitely constitute equal or even better tolerability than monotherapy, with additive benefits of glycemia and cardiovascular effects in all types of uncontrolled patients. Thank you all for patient listening. Namaste.